Transcutaneous oximetry is a relatively simple examination which is non-invasive and an essential part of selecting patients for HPO, determining whether or not they have healing potential and are candidates for receiving HPO, as well as determining whether the treatment has been successful and can be discontinued or needs to be modified. It consists of a peripheral series of equipment which include a razor to remove any excess hair that will break the airtight seal or gas-tight seal, then sticky tape to remove any dead cells of the stratum corneum, an alcohol swab to remove glue and any other oily substances, a ringlet that is applied to the skin to provide the gas-tight seal with the electrode, and a solution that bathes the electrode and brings it in contact with the skin and allows gas to then move outside of the skin into the electrode for measurement. The selection of the site is very important. It's usually the lower limb, and diabetic patients are of the most common referrals. The sites that are selected are very important. They should typically be concave rather than convex, and one should avoid bony areas as well as areas with major arteries. So for instance, the dorsalis pedis area and the tibialis posterior area are not ideal. Neither is the bony area over the pretibial surface. What we choose when doing assessments on the foot, when possible, is usually the first and fourth web space, sometimes slightly higher, again avoiding the arteries, and the posterior gastrocnemius area, which is where below the knee amputations would be performed. Once the areas have been identified where the electrodes are going to be placed, the area is shaved, then sticky tape is applied, usually up to about 10 times, when the tape no longer becomes opaque because of the removal of dead cells, and be very careful not to injure the skin. Then it is cleansed with an alcohol swab to remove the glue or any oily remnants or creams, and then the ringlet is applied. Now, very importantly, the adhesive surface of the ringlet must not be touched, and only use the tab as well as the ringlet surface or the ringlet protrusion to hold onto the ringlet. It is then applied and sealed very gently over the skin. 1 or 2 drops of potassium chloride are then added to this ringlet, after which the electrode is attached. The electrode is at this stage being calibrated, and we'll show you the calibration sequence shortly. It is turned anti-clockwise until it clicks, and then clockwise until it locks. The value should be 159 at sea level and would vary, of course, with altitude. Upon attaching it to the patient, you will notice that the monitor reading immediately begins to fall. This is an appropriate sign and an indication that there is metabolic activity in the skin under the electrode. So this is an expected response, and it may vary from patient to patient, and of course the metabolic activity of the skin underlying the electrode. At a certain point, there may be a reversal of the downward trend, and the higher the number in which this occurs, the better the prognosis generally is. You will see a timer on the left-hand side, which is a remnant of the time that these devices were used in neonates, and it was to remind people to remove and circulate the electrode to another site after a period of a maximum of 8 hours. So in this case, the value is dropping down to approximately 58 millimeters of mercury. Once the patient has stabilized after a period of 10 to 15 minutes, they are then placed on oxygen. By this time, they will already have been made comfortable in a standardized position, and the oxygen will then be applied. We want to provide the highest possible PO2, and therefore we use two choices, of which the most available one is usually the non-rebreather mask. It's pre-filled so that the patient never feels as if they will suffocate. It is secured over the nose, and the metal strip is used to make sure that it seals over the bridge of the nose as well. Now we start recording after every minute that elapses from the point of oxygen administration up to 5 minutes, and then at 10 minutes. So as the oxygen perfuses into the area where the sensor is located, we anticipate a gradual rise. Depending on how quickly this happens, gives us an indication of the underlying pathology, as discussed in the previous lecture. Here we can already see that there is a rapid increase, and the arrow now shows the trend is upward. The value that we would like to see should be in excess of 100 millimeters mercury. This is a normal patient without any pathology, and very quickly arrives at 100 millimeters of mercury. So they have already passed the test as far as the 100% oxygen 1 atmosphere challenge goes. At this point, we continue the monitoring from 5 minutes until 10 minutes have elapsed. Once the full 10 minutes have elapsed, the highest value is recorded, and that then becomes the final value of the oxygen challenge. Note that in some cases, patients who have proximal arterial disease may actually have a paradoxical decrease in the oxygen. After the test is completed, the test results are discussed with the patient, who is then advised what the implications of the test are and what the subsequent follow-up tests or interventions are likely to be. When calibrating a transcutaneous oximeter, refer to the manual to determine what the appropriate PO2 should be. This varies depending on the altitude. Air percentage remains approximately at 20 to 21%, but depending on the altitude, PO2 will gradually decrease, and it's necessary to adjust the value of calibration according to the altitude. That concludes our tutorial on transcutaneous oximetry.